Hello, everybody. It's such an honor and a pleasure to be here, and what a wonderful lecture we just listened to. So I am a lymphedema therapist, been practicing for almost 40 years. I also have lipedema, and I'm very, very passionate about helping. I read research all the time, so I'm not a researcher, but all the information I'm going to give you is from all the studies that I have read. So we're going to talk about the metabolic link in connective tissue disease. I have nothing to disclose, and we're going to discuss how metabolic dysfunction, chronic inflammation, and gut dysbiosis contribute to the progression of connective tissue diseases. You've already heard a lot about gut dysbiosis from Bonnie, and it's so important, and how chronic inflammation plays a role in the disease progression. We're going to talk about insulin resistance and altered fat behavior, and then touch a little bit on microRNAs, which are the latest studies for a potential biomarker for lipedema. And then, as always, I like to present on a holistic, integrative approach, managing these complex diseases. As the previous speaker said, it's an integrative approach, it's a holistic approach, it's a systemic approach always. And so with these diseases, it's usually a lot of obesity and fat, and it's difficult to lose the fat, and so we call this persistent fat tissue. It's very important to understand the complex interactions in adipose tissue disorders. There is a combination of inflammation, the immune system, the lymphatic system, the endothelial cells are involved, mast cells, and so we need to have a deep understanding of that to understand what we're doing and to treat these patients. Is it obesity or is it lipedema? Lipedema, as you know, is often misdiagnosed as obesity, but they frequently do occur together. So managing obesity in these patients, in our patients, is a very key component for the treatment. There are complications that are caused by obesity, because obesity leads to chronic inflammation and disorders of lipid metabolism, which then leads to chronic inflammation, and that can lead to insulin resistance, and eventually, especially in Dercum's disease and Madelung's disease, to type 2 diabetes. And that can also lead to atherosclerosis, cardiovascular diseases, non-alcoholic fatty liver disease, and even osteoporosis. So obesity, we know, is closely related with these fat disorders, and it's potentially exacerbating. There's pain and there's inflammation, always inflammation, and we need to treat that inflammation. And this all contributes to insulin resistance, which may explain the reason why there is a propensity to insulin resistance in these illnesses. Obesity transforms adipose tissue from a metabolically healthy state to an inflamed state. And when there is an inflamed state, the fat cells accumulate, and the size of the fat cells disrupt the normal metabolic processes, and that affects insulin, and also leptin. Lipedema fat cells release inflammatory markers that impair insulin's ability to manage glucose levels effectively. So these inflammatory cytokines, IL-6, TNF, they actually contribute to inflammation, but they also impair insulin's ability to manage the blood glucose. So just remember that. And as the fat cells increase in size, leptin levels rise. And when leptin levels rise, we have pro-inflammatory adipokines, and then it can impair insulin signaling pathways. So it's all tied in completely. So thus, adipose tissue becomes an active inflammatory organ, releasing these pro-inflammatory cytokines that we see in these connective tissue diseases, lipedema, Dercums, and Madelung's. And this exacerbates metabolic dysfunction. So let's talk about metabolic dysfunction. There is metabolic dysfunction in obesity, and these dysfunctional adipocytes secrete the inflammatory cytokines that I was talking about, and that reduces the protective adipokines and releases more inflammatory cytokines. There are some anti-inflammatory mediators, such as IL-10 and IL-19, according to the study that was done. And they talk in the study about the immunometabolic response of adipose tissue. It remains largely unexplored. We need to know more about it. And clearly in the disorders that we're talking about, there is an immunometabolic response going on. So what is insulin resistance? It is impaired cellular response to insulin, and that leads to high blood sugar levels and metabolic disturbances. That alters the fat metabolism and contributes to abnormal fat storage in these conditions. Patients we know have difficulty losing weight, and there is altered glucose metabolism, which further drives the progression of these disorders. And this is showing the pathway when people eat all the time. Some people are eating every 2 hours, and you're having high foods, nobody in this room, high white flour, and fast foods and packaged foods. When you're eating too many high carbs, that produces too much glucose. When there's too much glucose, the body secretes more insulin. And if that keeps on happening, the cells will not allow the insulin in anymore, and that's when we have insulin resistance. There's something called hyperinsulinemia, which is when there's high insulin in the blood. The pancreas releases extra insulin, and that's the major cause of inflammation. It causes insulin resistance. So for our patients, it's very important to have a low glycemic diet to avoid these fluctuations in blood glucose and insulin levels. So that looks really delicious over there. Metabolic syndrome, it's a combination of many, many symptoms, but I want to just show you in this slide the inflammatory cycle. So the obesity causes chronic inflammation, the chronic inflammation causes obesity, and then there's insulin resistance, and then the inflammatory markers, and it's a self-perpetuating cycle. You're on that cycle and it keeps going. So the most important thing we want to do is to reduce that inflammation, reduce the amount of glucose that we're having in our diet. Because when there is metabolic dysfunction, there is a disruption in normal metabolic processes involving the insulin resistance that I spoke about, but also mitochondrial dysfunction, particularly in Madelung's disease, and there's a chronic low-grade infection in all of this with the elevated risk of diabetes, cardiovascular, and other metabolic syndromes. So we look at the role in fat accumulation, and there is also lymphatic impairment that is involved by all of this that's happening in these disorders. And in this study, they spoke about adipose tissue becoming an active inflammatory organ, releasing pro-inflammatory cytokines. And these cells are in the lipedema, the Dercums, and the Madelung's diseases, and this exacerbates metabolic dysfunction. That is the perfect storm, absolutely perfect storm, because your insulin is affected, metabolism is disrupted, there's chronic inflammation, there's more inflammation, it's self-perpetuating, and then there's this feedback loop that I was talking about. And then the metabolic function is worsened even more. When there is gut dysbiosis, this amplifies both problems. And Bonnie spoke to you about gut dysbiosis and fiber is so important. And also when you have a high sugar diet, it will affect the bacteria, the friendly bacteria in the gut. So it will also affect metabolic function and inflammation. So it's very important to follow a correct diet so that you do not have gut dysbiosis. Because when these gut bacteria populations become imbalanced, we have increased intestinal permeability, leaky gut, and as these bacterial metabolites enter the circulation, you get altered bile metabolism and also altered hormone signaling. And this is the resistance to weight loss that all of our patients talk about. And it's everything that we've been talking about now that affects the weight loss. The glucose, the fat tissue, insulin, the mitochondrial dysfunction, and the dysregulated adipokine. And that leads to increase in fat storage. So lipedema fat is resistant to weight loss. But we know it can be done, but we know it's resistant to weight loss. Due to this metabolic dysregulation and the low-grade inflammation, which is the driver of insulin resistance. Lipedema-associated obesity in later stages have concurrent obesity, which increases the risk of insulin resistance. But even lean lipedema patients can have this metabolic dysfunction. And as the lipedema progresses to stage 2 and 3, there is a higher likelihood of insulin resistance happening. And this is a study with women with obesity and lipedema, and they evaluated many functions, and they found that there was a 48% greater insulin sensitivity, but with weight loss, the insulin sensitivity decreased, and it improved metabolic function. So inflammaging and meta-inflammation is a term that is used now in functional medicine, and it's referring to chronic, age-related chronic inflammation, cellular senescence in the fat tissue, damaged cells, reduced autophagy, which is the self-cleaning of all the cells, and oxidative stress. In meta-inflammation, which is metabolically triggered inflammation, which is what's happening in these diseases, there is excess metabolic dysfunction and then produces these inflammatory cytokines that we've been talking about. And I won't talk too much about this because it was covered by previous speakers, but there's studies showing the impact of metabolism on gut health and the elevated LPS levels. And in this study, they did injections of bacterial endotoxins to show how it actually created inflammation and then insulin resistance. There is a direct relationship between gut microbiota, hypermobility, and obesity, and also the brain. So in these metabolic tissue, there are challenges. We need to understand the role of everything in lipedema and in Dercums and in Madelungs. You can read that study, but I'm going to go on because I have a lot to say still. Research shows that Dercum's disease involves multiple painful lipomas with metabolic abnormalities such as insulin resistance and hypertriglyceridemia. And with this, to summarize everything that I've been saying, lipedema fat is resistant to traditional weight loss methods and can contribute to metabolic dysregulation, which leads to chronic inflammation, insulin resistance, and there is a risk of insulin resistance as there's the lipedema-associated obesity, and that lean patients can also get that. In these studies, they also spoke about the relationship between lipedema and insulin resistance, especially in stage 2 and 3, but they also said that the lipedema fat may have a protective effect and that the gynoid fat negatively correlated with insulin resistance, so there was a lower risk of diabetes in lipedema patients. But that same study said that there was a risk of prediabetes that increased in stages 2 and 3. And this is consistent with everything that we have been learning. Madelung's disease, there's mitochondrial dysfunction, lipid metabolism imbalance, and metabolic abnormalities. MicroRNAs are small RNA molecules that regulate gene expression, and the new research is showing a role in metabolic signaling and fat tissue dysfunction, and that these are potential biomarkers to help distinguish lipedema from obesity. So there's a study there, it's very exciting. So interventions, we want to target metabolic interventions, anti-inflammatory diet, gut microbiome modulation, and insulin sensitizing agents. Metformin, GLP-1, berberine, which is a supplement. We want to improve the gut microbiota with high omega-3 fats, polyphenol-rich foods, prebiotic fiber, quality proteins, and low glycemic carbohydrates. And also the anti-inflammatory diet, intestinal barrier support to help that zolanine regulation that they spoke about, with zinc and vitamin D to help the tight junk permeability, and butyrate, which is fiber, comes from fiber. Addressing insulin resistance, if you have flavonoid-rich foods, vitamin D levels, and stress management will also help with the inflammation. And to improve the insulin signaling, low glycemic index, physical activity is really important to improve the insulin sensitivity. Metformin, and regularly check inflammatory markers and insulin resistance. Sleep disorders can also contribute to these disorders. I could spend 2 hours talking about this slide, but time-restricted eating and intermittent fasting, specific nutrient timing, meal spacing. So if you're not doing the others, then 4 to 6 hours in between eating your meals, not every 2 hours. And there's a study that has shown that cold exposure with cold plunges can activate the brown activating adipose tissue. Low carbohydrate diets and high fat diets have been very good to help control blood lipid parameters. And I'm almost finished. Key supplements: berberine, alpha lipoic acid, magnesium, chromium picolate, cinnamon, resveratrol, curcumin, omega-3 fatty acids, and vitamin D are all important to help with insulin sensitivity. So to summarize, patients with connective tissue diseases often face a combination of metabolic dysfunction, altered fat tissue behavior, resistance to traditional weight loss methods, and localized inflammation. These issues stem from the unique pathophysiology of these conditions, which includes genetic, hormonal, and systemic factors. And so we need to have an integrative approach looking at the root causes of the insulin resistance and the inflammation, rather than just looking at weight loss. And I recommend going to an integrative doctor. I've already went over that with you. And then the call to action is physicians and therapists should incorporate a more holistic, integrative, metabolically focused approach to treatment. Patients need to be empowered. You all need to be empowered to advocate for yourselves for a more personalized and comprehensive care with more blood tests that are more comprehensive than the average doctor gives you. There is a puzzle. You have different comorbidities to somebody else. You have a unique situation. You need to find that puzzle, that piece of the puzzle. That's what I try to do when my patients come to see me. When you find that puzzle, then you can put it together and be on the road to healing. You need to play a role. So thank you so much, and here is my contact information.